Good afternoon, everyone, and thank you for joining us today for the fourth event in our ongoing series of virtual COVID-19 vaccine town halls presented by the Globe and Mail and the Royal Society of Canada. I'm Laura Stone. I'm the Globe and Mail's Queen's Park reporter, and I'm pleased to be your MC and host for moderating today's discussion. The Globe and Mail and the Royal Society of Canada have been collaborating for a number of months now on this series of town halls, and our hope is that these events will provide a public good in presenting the information that Canadians need in the fight against COVID-19 from leading experts across the country. And we have a great, very informative, wonderful panel set up for today. Before we get started and introduce our wonderful speakers, I just have a few housekeeping items to attend to. The first thing is for viewers. If you are experiencing technical difficulties, please let us know via the Ask box on your screen, and your questions will be answered as soon as possible. And thank you to those who have sent these excellent questions ahead of time. I've seen them, and I think we'll be addressing a lot of the questions that you have throughout the discussion. If you want to ask a question at any time during the panel, you can do so using the Ask feature on your screen, and those will be emailed to me, and we'll be choosing some to talk about throughout the discussion and afterwards as well. To everyone who registered for this webcast, you will receive a link to the recorded version so you can view the event again anytime you want. And we will also be sending links to further resources where you could find more information about COVID-19. If you'd like to follow the social media conversation, please follow at RSC the Academies for live tweets from today's events, as well as to stay up to date on any news and events from the Royal Society of Canada. And you can also follow at the Globe events for updates from the Globe's team. And finally, we will be hosting a fifth vaccine town hall on Wednesday, June 2nd at 2:30 p.m. Eastern. So you can tune in to hear an expert panel discussion about what happens after you are fully vaccinated and Canada's ongoing efforts to reach herd immunity, which we will also touch on during today's discussion. So without further ado, I'd love to introduce our panelists for today. The focus of today's conversation is a very hot topic in Canada and around the world, the COVID-19 vaccine rollout and what this means for the country's efforts to end the pandemic. Our hope is to offer some clarity on the subject and answer some of your pressing questions. And here today, we have four experts in the field. Up first, I'd like to introduce everyone to Dr. Carrie Bourassa, the Scientific Director of the Institute of Indigenous Peoples Health at the CRH. Welcome, Dr. Bourassa. Next, we'd like to welcome Dr. Carolyn Colleen, who holds the Canada 150 Research Chair in Mathematics for Evolution, Infection, and Public Health at Simon Fraser University. Welcome. Next, I'd like to welcome Dr. Shelley Deeks, who we often see on television giving NACI briefings and informing the public about the committee's recommendations. She's also the Public Health Surveillance Medical Officer of Health in Nova Scotia. Welcome, Dr. Deeks. And lastly, but certainly not least, please join me in welcoming Dr. Catherine Hankins, who is the co-chair of Canada's COVID-19 Immunity Task Force. Please welcome Dr. Hankins. Thank you so much. So I will start with the theme of this discussion, vaccine rollout. Where are we now? And I'd like to just start by asking all of our panelists to kind of give a broad overview of how you think Canada is faring, both in comparison to our neighbors in the South in the United States, but also around the world. So I'll get everyone to make some brief comments about just generally how you feel this country is doing in terms of the vaccine rollout. I'll start with you, Dr. Bourassa. How do you think we're doing?
Thanks so much. I think right now the uptake for at least in terms of the Indigenous community, we started out strong, and then we sort of had a bit of a glitch, and now I think we're having some success now after some setbacks. And I think that the success we're having now is because we have Indigenous leadership going into their communities, and they're getting their vaccines. The vaccine rollout is coming through the provinces and to the leadership. And I think that they have excellent plans, and so we're getting now, some really great uptake, particularly in Indigenous communities. Even though there is still some hesitation, I think that because we've really started to launch some great plans to sort of address a lot of misinformation, now that we're seeing a lot of strong uptake.
That's really great to hear. Dr. Colleen, I'll go to you next. What do you make of the rollout so far?
Yeah, so clearly we started out more slowly than the highest vaccination rate countries like the UK, Israel, of course, and the US. And I think we're picking up the pace now, which is great. I want to make a few comments about the details of the rollout. So we started, and I think absolutely rightly, with very vulnerable populations in the long-term care and the very elderly and Indigenous populations. And I think that's right. One of the things we've looked at is starting to ramp up now a little bit with a focus on people who are at risk of transmission and exposure. So the essential workers or people who can't avoid having high contact at work. And I think that's a really important piece because of what we know about the vaccine's ability to prevent transmission and not just prevent severe outcomes given exposure. So I'm excited to see that aspect ramping up to really get vaccines to where they're most needed to prevent exposures in our communities and prevent transmissions, because that's what's going to get us more in a position to reopen now that we've protected the most elderly and long-term care and most vulnerable.
Great. Dr. Deeks, I'd like to hear from you about your thoughts on the rollout.
So I think stepping back, Canada is in a very fortunate position in that we have vaccine. First off, most countries in the world actually don't have vaccine. So I think that we are very fortunate from that perspective. We are also very fortunate in that we have a supply of multiple vaccines. We have enough mRNA vaccines to vaccinate the entire Canadian population by the fall. And also have the viral vector vaccines as they come in. So I think the fact that we have a range of products also puts us in very good standing. Given the third wave that we're experiencing right now, I think the decision to delay the interval between the first and the second dose and get as many Canadians vaccinated as quickly as possible was actually a really important decision and has already saved lives in the third wave because of the protection offered by vaccination. I think some of the challenges are that Canada doesn't have one immunization schedule. We have basically 13 immunization schedules in many ways because we have the various provinces and territories who determine the programs within their jurisdiction. And that can cause a bit of confusion and I think can also impact confidence because we have slightly different rollouts in different provinces and territories. I know in the province that I am currently living in, Nova Scotia, we're now in the situation where more than 80% of our 70-year-olds and plus are vaccinated. And I think that's a very, very fortunate position to be in. Thanks, Laura.
Thank you so much. Dr. Hankins, I'd like to hear from you, and I'd also kind of like to throw this question to you as well, based on what Dr. Deeks just mentioned, the delaying the second dose. We've heard a lot from the audience questioning the efficiency, what it means for elderly people. So as a member of the Immunity Task Force, and as you're preparing for the G20 Health Summit in Rome next month, can you give us the pros and cons of delaying second doses in Canada, and what would be your message to the international community about that? And feel free to preface that with any general comments you have about the rollout so far.
Well, it's interesting. I agree completely with Shelley Deeks. We are very fortunate. Yeah, we got off to a rocky start and we had issues with logistics and we have uneven supply and demand issues that we're trying to address. But in general, we are really, really fortunate. And I just came out of the Quebec conference call that was just held on the plan. Within 2 weeks, it's opening to the general population. They're doing every 2 days, a 5-year increment down. There is just, they opened up to businesses who were interested in providing their own services if the government provided vaccine. I think there were like 450 businesses that applied. 10 are going to start on Monday vaccinating their employees. I think we're seeing across the country some creative solutions, and we need to be sharing those and cross-fertilizing to see how we could get the best coverage possible. I agree completely on what I call a pragmatic Canadian approach with the delay to 16 weeks. Maybe with the amount of vaccine coming in the end, it won't necessarily be 16 weeks for everyone. It'll be shorter. But I'm calling it a pragmatic Canadian approach. It's used in the UK. And initially, we saw these wonderful data from the UK, from Israel, Scotland, looking at what was happening in terms of declining new cases as vaccines got rolled out. There was a study that reported yesterday from England looking at household transmission. So they looked at 24,000 households where there was a COVID case, and they looked at the secondary attack rate in the household if the person who got COVID had been vaccinated or not. We know if you get COVID after vaccination, it's lower risk of symptoms. Most people are asymptomatic. This study showed almost a 50% reduction in onward transmission to other people in the household. And that's because with a single dose, you get a reduction in viral load. So I think we have both the population level data now, and now we've got the specific individual level data at households that tell us we're on the right track with this delayed dose interval.
Does anyone else want to weigh in on that? Because I think there are a lot of concerns in the public that somehow the vaccine will, to put it in layman's terms, wear off, or it won't be as effective because you're not sticking to the recommended dosing intervals from the company Pfizer, for instance, which has come out and said it should be 3 weeks. What do you tell people about waiting that extra time and whether the vaccine will be as powerful and efficient as sticking to the original dose recommendation?
So I would weigh in and say that the benefits that were described with the household study that Dr. Hankins described are so important in 2 ways. One, that this reduced viral load. The other, that we've prevented infections from happening in the first place. And so when we think about what level of protection a vaccine offers us, we're thinking about what if we get exposed. We need to also think about that we are so much less likely to be exposed if everyone in Canada can have a single dose because of that indirect protection. And so it's not that you're going to get COVID anyway and how much vaccine do you want? It's that you don't want to be exposed at all. And we can prevent that effectively by vaccinating more people with a single dose because you get more overall protection across the population. So I think that's an important piece to be considering when we think about whether I want my second dose. Actually, I might want my friends or my work contacts or the people who work around me to have their single dose more than I want my second dose.
Yeah, and I would like to add as well, I agree fully with what Caroline said. I would like to add as well that in terms of our immune system, the first dose provides an immune response, and the second dose boosts that response. From everything we know about our immune system with other vaccines, we don't expect a sudden drop at 21 days. And so typically even up to a 6-month interval for what we call a prime and then a boost is totally sufficient. So really it is about protecting more people sooner and then boosting people for the prolonged immunity.
Great. I'd like to go back to you, Dr. Colleen, just regarding this idea of herd immunity. And we've heard from federal officials recently that that they believe Canada can start to reopen or loosen recommendations when 75% of Canadians have their first dose and 20% have had their second. So, at what point can we or will we reach this idea of herd immunity, and how important is that?
Yeah, it's a great question because we don't really know, there's always going to be some kind of herd immunity to something. And the question is to what? To what level can we reopen, or to what strength of virus do we have that herd immunity? Our best estimates would suggest that if we have 75% with their first dose and some with their second dose, we'll be good to reopen quite a bit more than we are now, but not to go completely back to normal life. So we'll be able to reopen to a virus that, if we didn't have vaccination, would be infecting on average 2 others per infection, so a reproduction number of 2. That's probably quite a lot lower than the new variant of COVID the new variants would be if we just completely went back to normal. So I think but it is a lot more than what we can reopen to right now, or without considerable vaccination. So I think what we'll see is a slow and cautious reopening of some things, and looking at what happens in the data, looking at where that immunity is landing. Of course, that's a huge level of immunity in the population, but it doesn't include those currently not eligible for vaccination under 17. And it doesn't get to everyone. Ideally, we want 95% of people vaccinated. And I think that would provide us a much more robust, level of reopening that we'd be able to do. And that has been achieved in the UK. They're seeing over 90% in those 50 and up. So I hope that we can achieve that, because I think it will be really the foundation of how we're able to reopen.
And if anyone could weigh in on this, what does reopening look like at this point? I mean, I know it depends. Provinces are doing things differently, but in Ontario, for instance, we're under a stay-at-home order, and outdoor activities are banned. So, if you were advising the government, or if you could venture kind of a guess about what a cautious reopening looks like, what kind of picture would you paint of what we should be doing at this point, or I guess in the near future, if cases continue to plateau or go down and hospitalizations don't escalate further?
I would just say that it's a balance here. We're seeing provinces come up with regional approaches within provinces, which makes a lot of sense when there is different levels of epidemics and transmission going on in different areas of provinces. So I think a one-size-fits-all for the country is off the books completely. Even for your own province, a one size I think would be difficult. So I think it's going to depend on how much vaccine rollout happens. I see that Alberta has started to offer vaccines to 12 to 16 that have other conditions. Quebec is considering the same. We're waiting for a decision by Health Canada about 12 to 16-year-olds overall with the Pfizer vaccine. But, as Dr. Colleen has stated, not everybody is covered by what we're proposing. The population is under 18, so they're not part of our current strategies. So we need to really ramp up as much as we can the vaccination, and we'll watch it. Each jurisdiction will be watching very carefully to see what's going on.
And I would like to add, Laura, if that's okay,
Sure.
just quickly. Sorry, I didn't mean to interrupt you.
That's good.
I think the most important message now is that as soon as everybody's eligible, they really need to get out and get vaccinated, because we need our vaccine coverage as high as it can possibly be, because not 100% of people will respond to vaccine, and some people will have contraindications. So we want as many people vaccinated as we absolutely can, despite what postulated herd immunity threshold there is. What I think we'll likely see in terms of loosening of restrictions is you'll likely see some differential loosening for people that are vaccinated versus people that aren't vaccinated. So some public health measures may come into play that are distinguished between the vaccinated people and the non-vaccinated people. We probably will also see things like allowing visitors to long-term care, vaccinated visitors, and measures like that. But I agree with everybody that it will definitely be a cautious reopening that I'm sure we're all looking forward to.
Dr. Bourassa, I wanted to bring you in just about some comments you made in your introduction, just about the Indigenous rollout kind of taking off and then dipping again, and now you're seeing a pickup again. Can you explain why you kind of saw maybe that hesitancy come in a bit later? And I'm also curious about the younger population, the younger Indigenous population. Have most of them been vaccinated? Does it depend on the province? And are they more or less likely to be accepting of vaccines than older people in Indigenous communities?
Yeah, thank you for that. So I think that we're still, unfortunately, seeing some misinformation that is causing in some parts of First Nations communities where there's hesitation, and I think there's hesitation really across the board. But it really depends on the communities, and it depends on not only historic trauma, but also I think on some of the other experiences that communities have had, even with H1N1 and SARS. So it's it really depends, but certainly I think that there is some good experiences as well. And so we have, for example, some leadership that are, a bit younger, and they're really sort of coming into the community and sharing good experiences and leading by example, taking pictures. We actually have some emphasis on an Aunties Challenge and a Chiefs Leadership Challenge, sort of to try and get everybody excited about the idea of getting vaccination, and it's working quite well. So and it's not in every community, obviously, but trying to sort of share that yes, there's misinformation out there, but we have programs to sort of battle that misinformation, and that the community's leadership is vitally important. And there is a lot of younger people that are in the communities and sharing information, and that is really important. So I think that's why we're getting some uptake now, but it does kind of vary across the country. And I think also, before I stop talking, there is a difference also between urban communities as well, and so urban communities, I think, now are finally getting their rollout, and that there was some pause there, and there was not enough vaccines for the communities, particularly urban communities, and that also I think was difficult for the leadership, in terms of not having enough vaccines. So I think that now we're finally on the upswing here.
And is there any concern that people might not come back for their second shots, or maybe delay it further? I'm just wondering. This isn't just specific to Indigenous communities, although I wonder specifically. But I was seeing some reports from the United States, for instance, that people have just been putting it off because they couldn't get the same type of vaccine, or they didn't, for whatever reason, want to go back. Is this something that that concerns you could happen in Canada as well?
I think there is a danger in that, and we certainly, are working very closely, at least out of our lab in Saskatchewan. We're working very closely with the communities, trying to prevent that. It's really important that they get the follow-up. I know there's still a lot of hesitation, less than there was early on, but we really are trying to, have sort of a program for vaccination uptake, and still really working hard on misinformation. And it's at the direction of community, which is really important, so that it's not sort of us coming in saying, hey, we're the experts and we know what's going on. It really, really has to come from community. And that's why I think we're having some success, because it really is coming from them. And that doesn't mean that all of the community are really happy about everything, but that, they are leading. And I think that's the really important thing, because if they feel that they're in control, and they should be in control, it is their communities, then I think that's where we get, the uptake, because it is really about self-determination.
I do want to go to some audience questions. We're getting a lot on this topic of mixing vaccines, or if you get one type of mRNA vaccine, do you need to get the same one for the second dose? Can you mix and match? What if there's not the same supply available if you got AstraZeneca the first time? So if any panelists want to weigh in on what are the recommendations for what you should get as your second dose?
So I can start. In terms of from the National Advisory Committee on Immunization recommendations, what we've said is that you should try to get vaccinated with the same product that you receive first for your first dose. So if you receive Pfizer, you should have Pfizer as your second dose. But that if you received Pfizer and there was only Moderna, so that would be fine as well, given that they're the same class of vaccines. In terms of mixing the AstraZeneca vaccine with an mRNA vaccine, or the mRNA vaccine with the viral vector vaccine, we don't have a recommendation about that as yet. The good news is that there are ongoing studies happening right now, and we will receive the results of those studies and then be able to make an evidence-informed recommendation about mixing vaccine products. And that likely will be coming in June, which should be prior to the first group of people that received their first AstraZeneca vaccine.
Just before anyone else weighs in and we move on to another question, I do want to keep you, Dr. Deeks, and just talk a bit about NACI. Obviously the group has had to make many recommendations, including on the dosing intervals and AstraZeneca. Can you walk us through how these decisions are made and why the advice sometimes changes to the public?
Yes, certainly. So NACI is a group of 15 individuals and a chair, so 15 voting members and a chair. We make vaccine recommendations about vaccine use in Canada. They are evidence-based recommendations, but if the evidence is not there, we also make expert recommendations and are very transparent about when those recommendations are based on evidence versus expertise. In terms of the process, we look at vaccine safety, effectiveness, efficacy, as well as the burden of disease. But also, unlike the regulator who approves a vaccine for use in Canada, we'll look at ethics, acceptability, feasibility, economics, although with COVID, we're not looking at economics, and make a recommendation with all of that in mind. And that's why you see recommendations from the advisory committee, in Canada it's NACI, but elsewhere in the world as well, that are a little bit different than how products are licensed. And I know that the committee has been getting a lot of feedback about the change in our recommendation over time. And what we have always said with COVID is that the most important thing, given how urgently it is to get recommendations out there to our provinces and territories who make the vaccine program decisions, is that we commit to getting these recommendations out as quickly as products are available in Canada. But given that, we know that the evidence will emerge. So we've also committed to following that evidence and modifying those recommendations as evidence accumulates. That happened with the interval issue, but it also happened when there is a safety signal. So when there's a safety signal, no one ever expects a safety signal, but we're always monitoring for that. When there's a safety signal, the committee then needs to come together and again, revise recommendations. So revision of recommendations should actually make the public have a confidence in the committee's ability to continue to monitor the evidence and make changes when needed. Thanks.
So, Laura,
Thank you.
If I could just say one thing that I think is really important about the recommendations that Shelley just spoke about, and also Dr. Hankins, is that for Indigenous communities, sometimes it's really hard for them to sort of extract, this information and translate it into their communities. And so what we do out of our lab at Morningstar Lodge is we scan this information and then try to translate it not only literally into their own language, but also into information that is understandable and convenient for them, so that they can make those decisions. So, Shelley, when you're talking about, the vaccine and, well, what if I can't get the same vaccine? And then we can share and say, okay, well, Pfizer and Moderna are compatible, so it's okay, for you to do that. And so having that flow of information and us being able to, transition that into the communities, that's very, very helpful, because them trying to go through on the internet and figure out, what does this mean, it's very complicated, and it doesn't matter, if you have a PhD or you don't have a PhD, it's very difficult to understand what all of this means, and it's changing so rapidly. And so what we try to do is really take this information coming and transform it into something that is useful for the communities that we serve. So this information is very important, and we try to take great care in translating it into something meaningful, so that they can share this with their communities and their family members.
Great. I want to bring Dr. Colleen and Dr. Hankins back in with some audience questions here. The first, maybe I'll start with you, Dr. Colleen, because you mentioned essential workers as well in your intro. Someone asks, and I think this is more of an Ontario specific question, but it could apply across the country. But it says, with the constant pivoting on vaccine target groups for 60 and over, then essential workers, now, is there any chance that the second dose gets pushed beyond the 4-month window? If it does get pushed, would this render the first vaccine less effective? Maybe you could talk about kind of the shifting priorities in vaccine rollouts and whether there's any chance that people's second dose would be delayed even longer than the 12-week dosing interval.
Yeah, so on that second point, I don't think those delays are in the cards right now. I think we're more likely to see an increased supply and perhaps sooner second doses than the 4 months. So I think that's really
great.
I'm not sure about that. Don't know the details of the logistics, but that's a bit what I've heard.
Mhm.
From the point of view of shifting targets, I really think that goes back to this point about evidence-based thinking, and actually that being a sign that we should be trusting the recommendations as they change in the face of new evidence. And I think what we learned about the vaccines a couple of months ago from the data from the UK and Israel, where they had very high vaccination rates earlier than we did, was that vaccines are good at preventing infection and preventing transmission. We knew from the trials that they were really good at preventing severe disease in people who were exposed and who were vulnerable. And I think that was the basis of the really age-based rollout, because the risk rises so steeply with age if you get exposed. But knowing that we can prevent people from getting exposed in the first place with vaccination is a really strong motivator for shifting our strategy to make the most effective use of vaccines. So if you can prevent 10 exposures with one vaccine, that actually has a bigger benefit potentially than preventing one severe outcome, because you may prevent 10 severe outcomes with one vaccine. So I think that is a rationale for the shift. We've done some modeling work, and there's lots of other modeling work done by Public Health Agency of Canada and others that really show that that has a benefit in reducing hospitalizations, in reducing deaths, and that even if that did delay someone's vaccination by a few weeks, it is better not to be exposed during that whole time between now and vaccination. So I think that that is a sign that we're able to pivot our policies in the face of new evidence and in the face of new needs, and in the face of also evidence about the direct impact that COVID has had on neighborhoods that have a high proportion of essential workers who can't stay home, who can't distance, who don't work from home, who need to have contact at work. Those communities have suffered a disproportionate burden of COVID infections and also COVID deaths. And so I think there are really direct effect and equity implications for using vaccination to stop transmission for everyone and benefit everyone, but in particular to address those needs in those communities.
And Dr. Hankins, I want to ask you about this idea of booster shots. We've had a couple questions on this. Someone asks, some countries are rolling out booster shots later this year to cover new variants. Where is Canada on this? And another person asked, just generally speaking, how important are booster shots to prevent further lockdowns or further waves? We know that Canada has secured contracts for booster shots in the coming years, but maybe you could talk about the impact that they will have and how long you think we may be using them here in this country.
Yeah, so I think it's early for us to be trying to determine the need for them. I think I just want to reinforce what was said by Shelley Deeks and by Caroline Colline about the information that's coming, the scientific information in huge volumes every single day. So trying to curate that information and then translate it to the population so that the population understands that we are trying to get more certainty all the time, and that's what we're aiming for, and that having what I think NACI calls evergreen guidelines is good, because it means it's informed by the science as it comes forward. Now, as for just going back to the transmission issue, every single infection that's prevented reduces the chances that the virus is going to mutate. So this leads a little bit into this booster issue, because boosters, you can need them if you have waning immunity, meaning your immunity is falling. You can need them if the vaccine needs to be changed or tweaked to address new variants that are not being handled by the vaccines. So this is something we need to watch carefully. We're already tracking breakthrough infections right through the country. Anybody that gets reinfected after having had COVID, anybody that gets infected after having had the vaccine, we're trying to track those people, look at what virus they have, try to understand, are our vaccines holding? As far as what we have right now, our vaccines are holding, but that's going to determine whether there's going to be a need for boosters to address new variants.
Could I comment on this too? Yeah, I think it's so important to think that way and to think about what is happening with this virus next. So early in the pandemic, for the first year, the virus would have experienced selection acting in favor of an increase in transmission, because with most people susceptible, any virus variant that did increase transmission would have an advantage. And unfortunately, we've seen that with the B117 variant. Now, as we immunize large populations around the world, the selection will be acting in favor of a virus that is able to infect people who've been infected before or who've been immunized. And so it's really important that we roll out first doses as widely as possible to get the infections down. As we just heard from Catherine Hankins, every case we prevent is preventing an opportunity for the virus to change and to enjoy that selection that is acting. But then once we've done that, getting those second doses and or those boosters out is going to be really important in preventing a virus that is able to get into vaccinated individuals from spreading. And so it's really important that the single dose is really important, and the second dose will and or boosters will also be really important in terms of making sure this virus kind of stays what it is as much as we can. So I think that's an important piece that we'll need to move into after maybe that 12 weeks has elapsed, or hopefully even before that.
Can we talk about this idea of vaccine passports? Whether I think we mentioned that there might be, they might be used to visit long-term care, for instance, maybe not that in that name, but you might have to prove you're vaccinated in order to visit. Do you see this as the future, either within Canada, even for interprovincial travel or certain events like concerts or visiting a vulnerable population? Or is it going to become the norm worldwide when we travel, where we're going to have to provide proof of vaccinations in order to visit certain countries? Anyone can pipe in here, but I'm curious as to what you make of this idea, if you think it's actually going to happen.
So Laura, I think the horse is out of the barn in terms of international travel, because I think we're going to see, we're seeing other countries come up with, and they are, app-based things that are on your phone or whatever. I think we're going to see that kind of thing. In terms of what happens in Canada, I think we need to have an all-of-society discussion about this, about how this would work and how we can ensure that it's equitable. There will be people who won't be able to take the vaccine for various reasons. There will be people that would prefer to be tested frequently rather than get the vaccine. I think we need to have a big discussion about this right across the country, is my view.
Anyone else have thoughts on this? Whether within Canada, I mean, I know we've heard from the EU, for instance, fully vaccinated Americans will be welcome there this summer. So, yet, like you said, Dr. Hankins, it's already started. But do you think that we're going to see that for certain activities here in Canada?
Really too early to say. I totally agree with Dr. Hankins that there really needs to be a lot of dialogue. From my perspective, I really worry about the equity angle with that, particularly among vulnerable populations. From a global perspective, pre this pandemic, the only real vaccine kind of like passport was for yellow fever vaccine to be able to go into certain countries. Of course, whenever there's those sort of regulations that are implemented, aside from the equity issue, they're always open to counterfeit. So I think it's a very complex decision, both at a global level and within Canada.
I'd like to ask about the actual rollout of vaccines and in the different provinces. There's been lots of talk here in Ontario about all the various platforms that you can use to register, and maybe some of the confusion that has come from that, and feeling a bit like Hunger Games trying to get an appointment at a pharmacy. what can Canada do better, or what can individual provinces do better, if you want to just focus on one, in terms of centralizing this, making it user friendly, making it equitable for those who might not follow vaccine hunters on Twitter, for instance. What do we need to do to make sure that if this happens again, or as we roll out boosters and use these kinds of systems, that the rollout is a lot smoother and easier to navigate than it currently is?
I could speak just for Quebec, perhaps, because one of the big messages from here is that we have a common booking system for the entire province that was pre-existing before COVID came. And the government was really clear right from the start, what are the priority populations? You could go down and you could see that you were going to be 6A, and then you could watch to see when your turn would come up. Quebec has trained 12,000 years. We're trying to do things that are, ring vaccination around schools with teachers and parents that have got a variant already identified in a school. I think across the country, there are different examples that we need to be pulling up as lessons learned for going forward. But it's true that the more choices that you can give to people for access in terms of how far from their home, whether it's in their work site, whether it's because you're accompanying somebody else to a vaccination and therefore you're eligible as well, those are what's going to make the big difference. We need to learn from our mistakes and be much more flexible and create these sustainable systems for the future. And I'm sure that Shelley's going to comment, we need to have like a national, at least in my view, a national vaccine registry so that we know what's happening.
Yeah, that's exactly what I was going to say, that, Canada didn't have a national vaccine registry going into this. Certain provinces and territories did have provincial vaccine registries, but we didn't have a national one, which just made the rollout, from my perspective, much more complex. We would have been in a different place had we had that. In Nova Scotia, for instance, we created a centralized booking system. So there is only one system, which we got a lot of negative feedback at the start because the rollout appeared very slow, because a lot of the effort was put into building the system. Now, of course, things are moving quite quickly. Had we had a national registry right from the start, things may have rolled out more quickly across the country and in a more streamlined effort. The other thing, though, I think that's important to recognize is regardless of the system one has, it's really important that some of the booking or interactions really needs to be community driven, particularly for some of our most vulnerable populations. And so not to just rely on a single system, but to rely on ensuring that you have a system, but also are flexible enough to recognize where you need to pivot and do more engagement with communities to ensure your maximal uptake.
And Dr. Bourassa, can you weigh in on that? Like, what were some of the grassroots initiatives that you have seen in First Nations, and can you speak to some of those successes, and what be they? I don't know if they're pop-ups or just community-driven initiatives that maybe it wasn't people just registering on a website, but coming out to the community center, or people coming to their doors. Maybe you can speak to some of the initiatives that have happened that you've seen that have been successful.
Yeah, I was just going to say, I think that it's really important for communities that are not only Indigenous communities, but in my experience with Indigenous communities, there's many communities that are on reserve, are in rural, remote communities, even urban communities, right? Who they don't they're not connected to they don't have connection to internet, or they don't have the ability to look at the registry, or if they don't have their the ability to connect to those things, or not even to know where to look. I even had trouble to look on the registry. I had to get a phone call to go and get my shot. So, my vaccination. So, I mean, it's really, you have to think about some of the marginalized populations who don't have access to internet and these kinds of things, or to even know where to look. So I think it's really important. There should be community engagements. The leadership has been really great, I think, in doing that. They really took control. They went into communities, as I said before, and this really happened across Canada. I know there was many media events where they were talking about that even in the far north, they were going right into their communities so that they could explain why there were some vaccine shortages. And vaccine shortages was a real issue because they would get part of their communities vaccinated, and then all of a sudden they don't have enough vaccinations, and they didn't know when they were going to get any more. And so even when communities wanted to get vaccinated, well, they couldn't. And so then there's a sense of frustration. And that's when you sort of had the dip where it's like, okay, well, now we're not getting vaccinations, and misinformation is happening. And so now you're getting some irritants. And then people are like, well, why should I get vaccinated now, right? It's a whole host of issues that now people sort of get frustrated. And now you're back to square one again saying, but we really need you to get vaccinated. So, there's a lot of issues at play when you're working with communities, not only Indigenous communities, I would say. So these are things that I think are lessons learned, and that we need to sort of take this away and say, how can we improve on this? And again, it needs to be, as Shelley said, and I think Catherine as well said, that this has to be community driven and community led.
Dr. Colleen, I'd like to ask you a question from the audience. I think will be right up your alley, but let me know if it's not. It asks, does the activity of vaccinating act as a spur to the virus's mutations into more infectious variants? If so, are we confident we can stay ahead in this race?
So it's an interesting question. I don't think vaccination, there's any evidence at all that vaccination would cause the virus to do anything. I think if you compare two people, one vaccinated and one not, we know the vaccinated individual will be less likely to get infected. If they did get infected, it's unlikely, but if they did, they're much less likely to show symptoms and have disease, and they will have less virus in them. They'll have a lower viral load. And what that means is there's so many fewer opportunities for the virus to change. The most opportunities we have for the virus to evolve is if it has a large population. So it's in lots of people, and it's in lots of people in high numbers, where it's replicating and has that ability for mutations to arise. And if it sticks around for a long time, maybe in someone who's immune compromised, unfortunately, that's potentially a source of changed virus strains. And so we can mitigate that by vaccinating the carers and communities around immune compromised patients, vaccinating them themselves. So we can act to prevent the virus from having opportunities to mutate into more transmissible or higher, more vaccine escape types. But actually, we prevent that by vaccination, because we prevent those cases from happening, and we prevent those high virus population sizes. So hopefully we'll be able to do that. The other way we can do it is with these targeted and community-driven and community-led vaccination strategies, actually, because any virus that did figure out how to get into a vaccinated individual, in order to have that advantage, it has to see some vaccinated people. If we can keep viruses and vaccinated people away from each other by really focusing vaccination in sectors, in communities, in hotspots, that will also act to really reduce those chances for the virus to do that and to spread.
So we have a few minutes left. I'd like to kind of end on a couple notes, and I'll go around to each of the panelists individually. I think something that as more and more people get at least their first doses, I think that a lot of people are looking for guidance about what they can and cannot do. So maybe I'll start with you, Dr. Deeks, but what is your advice to people who've got one dose of the vaccine? What does it mean if they are with unvaccinated people, if they are with people who've had one dose as well? How does it change things? Or are people supposed to just operate as if they have not gotten a vaccine until they have until they're fully vaccinated with 2 doses? Oh, I think you might be on mute.
I knew I would do that one. Right now, what we're saying is actually that people that are vaccinated should continue to follow public health measures. And so they should continue to wear masks. They should continue to physically distance. There will, and that is whether they have 1 dose or 2 doses. There is going to be modifications of public health measures over time as we learn more about how effective that the vaccine is in reducing transmission. We've already talked today about the evidence that the vaccine does have impact against that. But currently, individuals should still follow the guidance in their provinces and territories and keep following public health measures until there's some modifications of those.
Oh, Laura, I would say that having 1 dose gives you a little bit of peace of mind. Having both doses gives you more peace of mind. But your behavior shouldn't change at this point. We really need to get the herd immunity level in Canada up. And we're going to be tracking it by looking at how many people have already been infected, how many people are getting immunized. And we're starting to see, perhaps maybe even Montreal is starting to show that once you can get up 40%, 50%, that combination, you can start to see transmission going down. So we're going to be watching the epidemiology, and that will inform what we, as vaccinated people, 1 dose or 2 dose, will actually be able to do. But the safe and the civil thing to do is to keep wearing your mask and physical distancing.
And I'd just like to end, I'd like to hear from everyone just briefly, maybe on a forward-looking or a hopeful note about when you think this will be over, and maybe this is not something that will ever fully end, or certainly maybe not by the end of this year. But what can you tell the audience about when things will get back to normal or more normal than we've lived with for the past year, and what are we going to be able to look forward to? Can we have a good summer? Is fall going to be great? Is next Christmas going to be able to be spent with our families? So I'll start just in order of introduction and just brief comments about your thoughts on this. Dr. Bourassa, I'll start with you.
Well, I think that a good thing is that people are getting vaccinated. I still think that we've got a ways to go. The elders that have been praying for a long time now have indicated that we've still got a ways to go, and we still have to be very cautious. Getting vaccinated is important, and as you've just indicated, that we have to still wear our masks and self-isolate when we have to, and make sure that we're social distancing. I still think that we have quite a way to go, to be honest, but I think that we definitely are on the right track, and hopefully hopefully, by the end of the year, we'll be in a very good situation. That's in the case that people do vaccinate and continue to be cautious and follow the public safety measures. Yeah.
Dr. Colleen, what do you think? Do you think the worst is over, or?
So I'm going to go out. Yeah, I'm going to go out on more of a limb here and raise a couple of possibly controversial points. So I agree, we should follow public health guidelines, and it would be totally irresponsible to recommend not doing that. When we think about framing public health guidelines for vaccinated individuals, I think we should do that after everyone has been offered a vaccine. It's completely unfair to say, okay, we only offered the vaccination to some people, and now those people get to go and do more activities. That makes sense. But we need the public to know that vaccination is our best way out of this. And we don't want to be locking down for another year or another 2 years, thinking that only 40% of people or 50 got vaccinated. If we know that vaccination is likely to lead to a much more normal life. I think substantial reopening is going to be possible in the summer, in mid to late June and early July, probably not completely back to normal, but back to much more like normal if we can get vaccination up to 90%. And I think that's achievable. It's achievable in the UK. It's achievable here. We need to be monitoring for the evolution of the virus. Evolution won't stop because we're vaccinated. So, and the virus will continue to be in the world for a long time. So I think we need to be monitoring for that and looking at the viruses that we have and sharing our data and doing those breakthrough studies and all of that. But I do think the picture is relatively optimistic, even if we can't just go back to completely normal as soon as we're 75% with a single dose. We can get out of this largely with vaccination. I think we will, and we need to be sharing that and planning for reopening with the public so that they can see a way forward and they see vaccination as part of that way forward.
Dr. Deeks, will NACI come up with some sort of reopening recommendations on that note, or do you think are you leaving it up to the individual provinces? And what are your thoughts on when we might see an end to this pandemic or an end to the worst of it?
Oh, no, NACI won't. That wouldn't be part of NACI's mandate to come up with the public health measures. That would be up to the provinces and territories. I think I'm probably not as optimistic as Caroline, but I'm very optimistic. I think when we'll be able to see broad changes depends on every single one of us. We all need to do our part. We all need to get vaccinated. We've all been impacted by this. And we all play a part in getting out of this. And so people just really need to get vaccinated when it's their turn. I see probably a fall timeline in my horizon. And that's where my optimism is focused on. One of the things that we don't know, is this virus going to kind of be a seasonal virus and replace other seasonal viruses? Like we've had a totally different flu season than we've ever had, almost no flu in this country. So we're going to learn a lot about our seasonal respiratory viruses in the next year. The other thing, just to leave, that I think is another important thing to celebrate, even despite the third wave, is that we are not seeing the same cases and deaths in long-term care, and that is particularly because of immunization. So I just close with saying, please, everybody, do your part.
And Dr. Hankins, I'll give the final word to you. When do you think COVID will be over, or is COVID now going to be part of our lives for a very long time?
Okay, so some days I'm optimistic and sometimes I'm less optimistic. It varies a lot, but I would say we're going to be working now on trying to prevent a fourth wave. And what we're going to do to get there is to get vaccination rates up as high as we possibly can. And I think all of us have made the point to everybody, it's not just for your own individual protection. It's your duty as a citizen to come forward and get vaccinated to stop transmission on to other people. As Shelley's pointed out, the impact on hospitalization and deaths in the elderly is so clear. It's so evident. So I won't predict anything. I think COVID will be with us for much longer than we will have wanted it to be, and that we should be using everything we're learning now to build back better, to build back fairer, and to anticipate the pandemics that are coming and make sure we don't get into such dire situations next time.
Absolutely. Well, thank you all so much. I'm a few minutes over, so we'll have to leave it there. But on behalf of the Globe and Mail and the Royal Society of Canada, I want to thank you all so much for joining us today. And a reminder to the audience that you will receive a link to this recorded webcast, and you can watch it again and with your friends and family, as long as you stay in your household. And thank you so much to all of our audience members for joining us today and for the excellent questions. We'll see you next time. Thank you so much, everyone.
Thank you.